meeting. We're going to go ahead and get started. Let's start by doing introductions, starting with myself. I'm Andalo Urbano. I am the community co-chair.
I'm Jan Park, I'm a governmental co-chair.
David Fox, planning council staff.
Rachel Miller, Public Health Solutions.
Kathy Hago, Chair of Board of Management and Situate Information Care Committee.
Jan Hootis, member of PSRA.
Carrie Davis, co-chair Needs Assessment Committee and LGBTQ Center. Welcome.
Daniel Castellanos, Paris for the Homeless, co-chair of the Needs Assessment.
Adrian Guzman, co-chair of the Policy Committee.
Eunice Casey, HHC. Michelle Bacon, New York City Department of Protection Governmental.
Steve Hemrod, member of the Finance Committee and Priority Setting.
Alex Stukovich, Homeless Services.
Peter LaCour, New York State Department of Health, for at least 3 more days.
Amber Casey, New York City Department of Health, grantee.
Tom Petro, Westchester POH, for at least 2 more weeks.
Zach Hennessy, Wyckoff Heights Medical Center and Integration Care Committee.
Carlos Rosario, Public Health in the Bronx, Policy Committee.
So Reyes. Lenny Pierce, co-chair of the Civil Committee.
Nina Rothschild, planning council staff.
Freddie Milano, Community Health Care and Priority Services Committee.
Thank you. And next I'd like to invite Billy to lead us through a moment of silence.
Today we put a moment of silence to reflect back on this event that all began. Our fight against HIV and AIDS. Let us remember those who have fought and died and can concentrate on the struggle that continues. Thank you.
Thank you, Billy. So next up we have public comments. We have at least one. Okay. So we don't have anyone on the list for public comment right now. So we will move ahead into the next part of the meeting. Jack?
David, you want to review the minutes for us?
They were sent out yesterday morning. Hopefully you had a chance to look at them. They're concise. Any changes, additions, amendments? Not? Minutes, yeah. Thanks.
Okay, today is a fairly perfunctory day. This day's meetings will be about the work that committees are doing. We don't have a special presentation per se. Over the next few months, we will have some guest speakers coming to speak to us about trauma-informed care, about the New York State District program, about a new initiative launched by the Health Department called the Care Status Reports. But today it's basically about us, and I'm going to spend a minute just reviewing the materials in your packet before we get to saying farewell to Tom and Peter. So in your packet there are a number of documents. One is a PowerPoint presentation on 2 issues that will be presented to you by the Policy Committee on health literacy and local pharmaceutical assistance programs. And we'll get to that in a few moments. Also in your packet is some materials from AIDS Map. And it's a summary of a number of reports that were delivered at CROI, which is a conference that was held earlier in the month, a scientific conference. And I'll highlight some of those articles. But this is one collection of all of that work in one place that I found that it's pretty thorough and it can lead you to other places. There are about 60 reports that were issued from there, and this happens to be one of them. We'll be voting today on a couple of matters. One of them is a letter to the mayor asking him to support two pieces of legislation in Albany that address mail order pharmacies. The second letter is one that's addressed to the chief executive officer of Bristol Myers Squibb about the high prices of HIV medications and the rates that they're charging for two popular HIV medications, Taz and Cystine. There's also a letter in here that's addressed to leaders of both the House and the Senate, and it's in relation to budgets that have approved by the House, and one's currently being debated in the Senate for the next fiscal year. And we'll talk to that about that in a moment. There's a grantee report in here, which will bring you some very good news that we've heard from our funders in Washington. And then there's an April calendar, which is pretty complete. There's just one meeting we're not quite settled on yet. So I want to take time here to say farewell to two long-term planning council members, Tom Petro and Peter LaCour. I'm very jealous, and we get to retire before I do. Peter's been with us, well, they've both been with us, people living with HIV and people working in HIV from the very start of the epidemic here in the city. And Peter and Tom, and to some degree my path, have all intersected and intertwined over the course of time. I began working with Tom early on in the early 90s when he was working in the Mayor's Office of AIDS Policy for David Deakins, and I was working also in the Mayor's Office Constituency Affairs. We were in the same building. And he helped actually form this current HIV Planning Council, which still exists 25 years later. He also helped form the Tri-County Steering Committee, which some of the members are here today, and it's a pleasure to see you here. And Peter has been in and out of AIDS work from Baltimore to many other places, but most importantly with the New York State Department of Health and the AIDS Institute, where over a course of time he helped to engage communities that had long been sitting in the bleachers and standing outside of the room. To the extent today that LGBT issues about sex with men, both with regard to prevention, treatment, and care, are part of the normal nomenclature in the state health department. And much of that is owed to him and his efforts in raising awareness around the epidemic in those populations. So it's a bit of sadness that I get to see them come and go, but it is with great gratitude and appreciation that on behalf of the Planning Council and the Mayor of the City of New York, we bid you farewell, but we also know that we'll be seeing you in other places. I know I'll be seeing Tom at the G-Bar, but Peter has promised to come to the Integration Care Committee, so I know I'll see him. And if there are members of my staff that wish to say something at this moment, or Rachel, others, please take the opportunity now.
It's been a pleasure working with both of you for many, many years. Tom was the first staff director of the Planning Council, and I joined, I think, just after you left, but I've collaborated now with you for 16 years in the steering committee. You've been an incredible advocate and resource for longer than I have. I've been around a long time. So, and Peter, you're a fabulous artist. We'll really miss both of you. Yeah. That's all I can say. Really miss her. And I'm also jealous. you're in time for at least another 12 years.
Oh my, Peter, this really better be it, because we've been trained together so many times when you said I'm retiring in X months or weeks. Here we are a few years later. And I'll miss those collaborations and having you pop up at meetings all over. Tom, who am I going to gripe about our mutual contract funder with now? Oops. It's the New York City Part A contracting infrastructure and environment is different in many ways from Tri-County, but obviously we're managing the same parameters, the same requirements, and the same challenges of implementation, and it's been invaluable to be able to bounce implementation ideas off of you, Tom, and to see how you and your team are doing this. But I think what will stay with me the most is not the contracting work that you've done in which you've developed such an expertise over the years, but your wisdom at these meetings and breaking through impasses and bringing a level-headed, calm counsel to what have often been heated controversies here, whether it's a spending plan issue or interpretation of HRSA policy or what have you. It's been, I've been your colleague with a sense of awe and admiration, and I wish you both much happiness and luck in the next chapter.
Amber?
Obviously, I have not been in New York City very long, only a couple of years, but both of you have been so welcoming to me. And then as the grantees, our relationship with the state isn't just about being two government organizations, but about being people and being able to sit together and collaborate and disagree and have competing priorities or ideas, but always knowing that we're working towards the same goal because our constituents really are the same. So thank you so much. And Tom, you were probably even more so than our relationship with DHS. Yours and my relationship is so different. You and I talk on the phone much more frequently. I always bounce ideas off of you. You give me that historical perspective that I don't get as someone who has only been in the city for a few years. So thank you so much. And it's been great working with you. As you know, we really don't know what we're going to do about you quite yet. Thank you so much.
So Tom and Peter, please come up to the front of the room for this humiliating 5 minutes. Billy, go ahead.
I just want to, in sitting out in the audience as a consumer and being on the planning council, I watched these two gentlemen show leadership and show how even in our trying moments we can maintain a cool leader. And I thank you gentlemen so much.
Peter, in honor of your hard work and dedication as a governmental representative to HIV, Health and Human Services Planning Council of New York, I'd like to present you with this award.
And Tom, also in honor of your hard work and dedication as a governmental representative to the Planning Council, I present you with this award. Okay, on to the work of the council. I want to report out, and we're going to go welcome to join me this time. On some activities that may be of interest to you. First and foremost is AIDS Watch, which is a national advocacy day that takes place in Washington in April. And there are a number of organizations that are sending consumers to Washington to make round-the-hill visits to their elected officials. And I wanted to call that to your attention. Kimberly, is Harlem United sending a bus?
GMHC and Harlem United are partnering together to send a bus down on the 14th. So.
UNAIDS is developing a strategic plan, and we here in the health department have a strategic plan for the planning council, and the end of AIDS is a strategic plan that has been put together by the state. Well, there's also a strategic plan for HIV and AIDS for the world that's being put together by UNAIDS, and they are consulting with us and other jurisdictions across the country. They've circulated a paper and are seeking input, and I was fortunate enough and honored enough to be a part of that initial conversation. The plan is 90-90-90. 90% of people living with HIV to be tested. 90% of those people who have been tested to be engaged in care. And 90% of those who have been engaged in care to have viral suppression. Sitting on the call made me very conscious of the work that we do here and the way that we go about doing our work and being clear with our goals and objectives and what we think that we can obtain and what we visualize that we can obtain. And they have a very broad vision. If you think about women in some countries in this world who can't drive a car, aren't allowed to drive a car. Or you think about some countries that outlaw homosexuality. Or you think about some countries where there isn't clean drinking water. To put together a plan for HIV seems very challenging. We have to take into consideration all those other factors. Once the document is in its final form, I'll bring that to you and I'll report back to you on those activities. Also, in the packet, I noted earlier that there's a document here about CROI, and we in the health department have been having numerous brown bag lunches with people who went there and presented there and came back there to share with us what they discovered. And there were many wonderful things that occurred at that conference. I'll just give you some bullet points. There is a long-term cure for people with hepatitis C. This has become a major line of discussion in many of the committees of the council, and we'll talk about that a little bit later. It was identified that statins may reduce the risk of heart disease in people with HIV. Bristol Myers Squibb, who we're writing a nasty letter to, but nonetheless, they've identified the first in-class HIV attachment inhibitor. It's been successful in phase 1, phase 2 trials. It's now in phase 3 trial, so it's another line of defense against HIV that's been developed. A study was done that shows that financial incentives do not improve linkage to care or viral suppression in the U.S. This may come into conflict with some efforts that are being done here by some AIDS service organizations to use those types of incentives. Bristol Myers Squibb also introduced a second-generation HIV mutation inhibitor and has shown good results in safety and high potency for people who have become resistant to other types of medications. And a week on and a weekend off cycle of treatment has proven to be successful in young people. So on the horizon, we see many things. New medications being developed. In studies right now are injectable HIV medications, where you have a monthly injection. In studies right now are all forms of different courses of treatment, of cycles of treatment as prevention. And to me, whenever I read this and see this all put together in one place, it gives me hope. It gives me encouragement to come back here and go through these experiences because we're all part of that fabric. In your packet also is a letter from HIV Care Access Work Group and the AIDS Budget and Appropriations Coalition. We did not, as a planning council, sign on to this letter, but the CARE Coalition did, as did many other national advocacy groups, and I just want to say a few words about it. We now have a Republican House and a Republican Senate, and their efforts to reduce spending have been reflected in the budgets that they have brought forward in this session. It also reflects their desire to overturn Obamacare. It also reflects their desire to slash safety net programs. All of this within the context of Speaker McConnell saying there's a promise of a better tomorrow. Proposed cuts to Medicaid, proposed cuts to food stamps, proposed cuts to welfare, proposed cuts to student loans. $5 trillion in deficit reductions is what they say. There are also 600 amendments being attached to the Senate version of the budget. All kinds of pork barrel legislature on the horizon. And they want to convert Medicare into a voucher program. So this letter says, from our AIDS and HIV advocate partners in Washington, not a good idea. Not a good idea to propose a budget that will not sustain our commitment to Medicaid and Medicare. Not a good idea to support progress that would repeal healthcare reform. Not a good idea for massive and arbitrary cuts to discretionary healthcare programs. So as this plays out over the next few months, both at the federal level and we're looking at our state budget and our city budget, money changes everything. Money changes healthcare, for the good or for the bad. And we need to be vigilant about that. And so as the numbers start to bubble up and become real, and we have a sense of what the effect of that will be on our programs, we'll share with you that information. But in the meantime, we'll continue to say, not a good idea.
Right, I'd just like to add to that by saying that Jen started by talking about AIDS Watch. The AIDS Watch is really an opportunity to go and meet with or representatives in Congress and remind them of why it's not a good idea to do these things that are proposed. Even though here in New York, a lot of our representatives get that, it's important that they have the human stories to share with their colleagues in Congress.
So we have a suggestion. We've been working with, we discussed this in the policy committee. Not every one of us can get on a bus and go to Washington. Not every one of us can take time out of work to make that trip. But you can do that here. You can get on the subway and go to your congress member's office and schedule an appointment and sit down with them if they're having a home visit, or sit down with their health policy staffers and bring them up to speed on what we're doing and talk about the issues that are of concern to you in their work in Washington. So we would like, and we will send out an email asking that you identify your congressional representative. We've developed in the department internal packages that look at the epidemiology of Carol Maloney's district they look at the HIV epidemiology of Gerald Nadler's district. We know what AIDS service organizations are situated in that Congress member's district, and we have some sense of what Rhineway dollars come into that district. So when we go knock on the door, it's not just a handout. It's all sharing information with them and saying, this is real. Your district has $40 million coming into it to take care of 4,000 people living with HIV right down the street. It makes it real for them. So this is our effort over the next 6 months to see and travel with you to meet with your congressional representatives here in the city. It's an easy thing to do. It's a lunch hour. So I'm hoping that you will participate in that with us. And if you feel like doing that, when we send an email, please let us know the member of your district. We will work with you directly. We will help set up the appointments, and we will travel with you to the member's office to talk about HIV.
Thank you, Jen.
Can I ask a quick question? Are there any particular representatives that you are targeting that you want to reach, or is this a general everybody thing?
It really is a general everybody thing, but the one member that we're most interested in meeting with is Congressmember Nita Lowey. So for those of you who are in Westchester County and parts of northern Manhattan, it would be most helpful if we could make a targeted effort to reach out to her. It's very difficult for us to reach her in Washington when we're doing mill visits. Even with the most influential contacts that we may have inside the Beltway, trying to get an appointment with her has been a big challenge, and she's on one of the most influential appropriations committees in Congress. So keeping the message up in front of her would be really helpful. And sometimes, to be quite honest with you, the chances of meeting the member themselves is fairly slim, but that's okay. If you're meeting with their senior health policy people who report back to them that they depend on when a piece of legislation comes through, that sometimes it's even better because they're much more familiar with how those things are developing. So don't let that discourage you. But if the member is visiting in the district, you might have a better chance of meeting with them.
How do you spell that name?
How do you spell the name?
Nita, N-I-T-A-L-W-E-Y.
Just to add to what Dan was saying, that she in particular, I mean, most Congress people would rather talk to people in their districts, their own constituents, but she in particular is very picky about that. So you can barely, like, you have to present what your address is, just to get an appointment. So it would be really great if folks in her district could make that happen.
All right, any last thoughts or comments? Okay, all right, seeing none, we're gonna move ahead, and I'm gonna invite Adrian to lead us through, the update from the policy committee.
Hi everyone. So the policy committee last Friday, March 20th, and we had our usual shared updates on federal, state, and local budgets and other funding streams that affect New Yorkers living with HIV. And we also kept each other up to date on various litigation and other policy issues, and all of that information is always posted on the website. And from our policy committee meetings, we draw one or two items we wanted to share to a larger audience here at the Planning Council. And this week, or this month rather, we wanted to talk about an HIV/AIDS worker survey that the Black AIDS Institute conducted some time ago and released the results a few weeks ago, and also Jen mentioned this earlier, the local pharmaceutical assistance program proposal related to workers living with hepatitis C. So first, if you want to turn to, I guess, the first page, the second slide of the policy committee hot topics, This was actually really interesting. This was something Nina brought to the attention of the policy committee, not only for sort of general interest, for a lot of people around the table, the policy committee meeting to our service providers and news organizations, staff, a lot of workers who work with people with HIV, but we also wanted to see if there's anything that the planning council can do based on the results of this survey. So the survey is called When We Know Better, We Do Better, the State of HIV/AIDS Science and Treatment Literacy in the HIV/AIDS Workforce. And it was conducted by the Black AIDS Institute in conjunction with the CDC, Latino Commission on AIDS, NASDAQ, Johns Hopkins, Bloomberg School of Public Health, and Janssen Therapeutics. So essentially what they did was they conducted a survey of more than 3,600 respondents related to the knowledge and attitudes of HIV workers. So on the top of page 2, you can see that they drew 3,600 respondents from 48 states, DC, and US territories. 54% were men, 57% were people of color, and 41% worked in the South. And to be clear, these are workers who are not necessarily clinical workers, not clinicians, not physician's assistants, not nurses, not social workers as well. These are case workers, case managers, things of that nature. And when they compiled all the results, they found, as it says, disturbing results. You can see at the bottom of page 2 that the average score on HIV science and treatment questions was 63%, which received a grade of D. Just basic science questions about HIV, the score was 76%, treatment questions was 56%, and questions regarding clinical and biomedical interventions was 46%. So how did New York do? New York had an overall grade, this is on top of page 3, of 62%, which is a D. We are slightly above the national overall grade. You can see that the grade distribution sort of centers rather low. The average percent correct by question category, for all questions, 62%. When it comes to basic knowledge and terminology, only 74%. Treatment issues, 55%, and clinical knowledge, biomedical interventions, 46%. So as you can see, as the questions ask for more specific information about treatment and clinical interventions and PEP and PrEP, scores reduced. Yes?
Is it possible to distribute a copy of the survey itself?
Yes, it's beautiful. It's in color and it's very detailed. Nina brought, I think, just the exact summary with it to the policy committee meeting. So we'll post a link to it online.
Send the link. The full survey is 180 pages, but I'd be happy to send the link to the committee. And how long does it take to complete the survey?
How long?
The survey itself to complete? I don't know. No, the report. I'm sorry.
The survey will be in the report itself. The report with all of the findings is what's 180 pages.
Yeah, and they provided state by state by state. So I can send you a link to that. That's all we have. Can you just print it? I think the survey itself.
The reason I wanted to see the survey is I think that would be interesting for us to see the questions that they are asking, and also for us to be able to assess, is that in fact the way in which we train our staff to provide services? Do you know what I mean? Like, these are pretty serious findings. Let's take a look at what the survey questions were.
Yeah, and I think everyone should take a look at the survey itself, because I think it's important to know how the survey was conducted, under what circumstances, if there was any variation in scores by the number of years a worker has been at a specific agency. I think it's all interesting, and they go into very detailed findings. These are just a couple we cherry-picked to present. But for anyone that works at a service organization, I think it's really crucial to take a look at it.
Just a quick question. How did they define HIV/AIDS?
Well, it was not a clinical. There was no clinical aspect to their work. It was intake coordinators, caseworkers, case managers, things of that nature.
Line staff, not clinicians. And as somebody here just alluded to, if you had been in the field for longer, generally people who've been in the field longer did better. People who were PWAs did better, but overall the results were still not good. And just to be clear, the material that Adrian presented on New York, that's New York State as a whole, not just New York City, but since most of the, cases are in New York City, probably, I don't know exactly how many of the organizations and workers surveyed were from New York versus from the rest of the state, that I can't determine, but I just want to be clear, it's not just New York City.
I'm pretty sure I took this survey.
Oh, great.
I'm sure I got all the answers right. It was at a conference, and it didn't take that long, but I recall getting an Amazon gift card. Yeah, so it was like, I don't know, maybe 15 minutes?
It was all written, or laptop, or?
It was iPad.
So the take-home message then are the recommendations that the authors set forth. They had a couple. One, implement a national program to enhance HIV science and treatment literacy for non-clinicians working in HIV. Determine well-defined and detailed basic capabilities. Create a national certification program for HIV workers. Mandate that HIV workers continue with ongoing education. And also significantly raise the number of people with HIV among workers in these settings. So, I think that anyone who works in a service organization would have similar thoughts about this as well. So we wanted to sort of present this, and we had some discussion of it in the policy committee meeting. One, to just inform everyone about it, but two, to see if we can have a discussion at some point about what the planning council can do to ensure that all of our clients are receiving the best care possible by well-informed workers. So we wanted to sort of put that out there. The second update we wanted to give was on local pharmaceutical assistance program proposals. So HRSA permits all EMAs to establish a local pharmaceutical assistance program, LPAPs, and the LPAP coordinates with ADAP. HRSA permits them to be established to offer medication support when an ADAP program has a limited formulary or the conditions for financial eligibility are limited themselves. So it's sort of a backup plan when ADAP is limited in what it can do. So currently, our EMA allocates $8.7 million to the New York State ADAP, but the New York State ADAP does not pay for the newer hepatitis C medications simply because they're prohibitively expensive. So just to give you a little background on what we're talking about with Hep C here, it's a rough approximation of people with HIV who are Ryan-White clients who are co-infected with HIV is about 4,600, 4,700, about 24%. And the Planning Council contributes $8.7 million to ADAP annually, but this does not pay for newer hepatitis C treatments. So I think everybody's aware, and I think we may have talked about it at a previous Planning Council meeting, but the newer treatments are very highly effective, but their high cost can't be sustained by ADAP as it is. So just to give you an idea, the approximate cost of treatment that the new medication is $100,000. So we are sort of floating the idea that the EMA should consider an LPAP as a program that could assist some HIV hepatitis C co-infected clients with the cost of the newer medications. So this is already happening in some EMAs. So some steps that we're taking at the committee level is that the Needs Assessment Committee is going to contact those EMAs who have already established the LPAPs. An example is Atlanta. The Needs Assessment Committee will also examine the hepatitis C drug pricing. There's a lot of advocacy happening right now to bring the prices down, and we're definitely tracking that. And the committee will also explore a price reduction with pharmaceutical companies, and once they have that information, they'll report back to the IOC. Now, if an unmet need is identified, if it looks like this is something that can be addressed by Part A funding, then the IOC committee will develop a service directive and provide a cost estimate, and we'll talk about it as a planning council. So there's a couple steps before we can start talking about this in real, actual terms, but we wanted to kind of keep you updated on an idea that we had to bring this into play. Jen, do you want to mention anything more about this? A lot of work's happening in several other committees too, so it's kind of a piecemeal.
That's all? Thank you. You know, I find it very curious that, about the survey, that in all this time that I've been in part of the planning council, a year and so, one of the things I usually talk about is that idea of knowledge in the consumer and how I've been trying to relate the subject to you, and that data that is a survey professionally done seems to imply much more than the word or experience, let's say. So I'm glad that you are saying that we will consider the subject, but I think when we relate to that past surveys that you've done for the clients of Ryan White, and even when I went to the conference, the retreat, which was supposed to be about quality and the relations with client. There were some of us who were expressing that, but again, I see the enthusiasm today and no enthusiasm when it was presented to you before. So it's a challenge for a consumer to be thought as taken into account when we're trying to relate that personal experience. And it disturbs me, because that's the purpose I came to participate. For me to be heard. And this moment just really throws me off. Because I understand it's important data, because it's scientific, it's clinical, but the personal experience of a consumer, then what's the point? Just leaving it at that.
So, I just want to make sure that I'm following what you're saying. You're saying that sort of your personal experience as a consumer, and you feel that your personal experience as a consumer, and possibly other consumers feel the same way, is not fully taken into account as we develop programs and plan services, or I just want to make sure so we can, use what you're saying.
Yes, I've been sitting and I participated when last year the survey was discussed. Yeah, it's on.
Yes.
Yes,
Yes, it's right, so it's on.
it doesn't show here. No,
Okay.
but it's on here.
That's right.
And I thought there would be an impact on that particular survey, on the directives that we were doing. And then when I went to that particular conference and I relayed experiences, and I remember it was an emphasis on data, because there was a part that was about data and the other part was about consumer, the programs geared to consumers. Yeah, there were two sets. And I experienced enthusiasm about data, how important was data. And I think one of our peers was there to say, and he was talking about giving money or incentives, monetary incentives to programs, and he spoke up. And the reaction was numbing. There was nothing. And again, I see this pervasive underneath. That's what I'm trying to say. And now that you speak about it, a survey that expresses the confusion that even a consumer experiences when the first contact be intake, be peer, and the knowledge they provide, you find out that it's not sufficient, because when you compare it to your doctor or that social worker who has the professional degree, like, for example, in Hassan or whatever other program you belong to, we all go through the same process. We have seen it, and I came here to speak about it, and I've been speaking about it. What I'm saying is that at this moment right now, everybody goes, oh, okay, we have data. That's what I'm trying to say. It doesn't make us feel as participants. Since I've been here a year and so trying to speak about this. And now you say, the data is here. That's what I'm trying to say. And it's discouraging.
You feel that it's kind of what you're
It's just that I imagine that when you express, wonderful, now we have data as basis for change to reassess us. But you've been having it all along, and we've been trying to tell you. But I don't think you're listening. Sorry, that's.
Thank you for that, Sal. What I gather from what you're saying is that, there was limited movement on this particular issue until you speak. I think you're saying that now that you have data, that people are now listening. I kind of, have a different perspective of that. I think this body has been listening all along. I think we've been asking for the consumer perspective. I know I give a consumer's perspective, and for those who I am engaged with, and I think it has been reflected in some of the service directives that we have actually produced in this body. So I think maybe you're seeing that, a lot of things, the light bulb doesn't go on until you actually have data. I mean, a lot of things got moved on until you have data, so you say, okay, this is where we need to focus our attention. But we've been giving that type of feedback all along, I agree. And so, I don't want to point the finger at any individual, but I think that there is a concerted effort by this body to take into consideration the consumers. That being the case, when we talk about the power of quality improvement, providers and consumers improving care together, that conference that I presented a particular workshop on the power of consumers in quality, I think there was an ambiguous thought or thinking about this particular conference. It specifically says providers and consumers improving care together, which led me, and I had an aha moment even while presenting, that this is about providers talking to providers about what they're doing for consumers or to engage consumers. It wasn't so much about the consumers involved in the process of what providers are doing or having conversations or input to what the providers would provide, but more of the feedback on their presentations or what they've implemented that engage the consumers. So my question at the conference was, how many providers are educating their consumers on quality? And it was like the hush fell over Jerusalem. No one responded. And I was like, oh, okay. So we're not really getting the consumers engaged and involved in what they're implementing or providing. We're just formulating from what we're being told by what we hear from consumers. We're deciding for them what we need to do and how we're going to engage, and then it becomes manifested in whatever they do. But I think even at the conference, I felt like there wasn't enough engagement with consumers.
Can I just clarify something? I just want to make, I understand completely what you're saying, but I want to make it clear that we're presenting this just as another tool in all of the Planning Council's efforts to get a better idea of what's happening on the ground. I think our primary tool is the feedback from the consumers, but this is valuable in, one, it's reflecting 3,600 respondents across the country. So there's that, but it can never substitute for the direct feedback of consumers and the HIV community here in New York. And to be clear, there's been no action on this besides slipping it in the packets today. This is just something that came out. We discussed it at the policy committee last week, and we wanted to pose it to everyone here to get an idea of what's happening across the country. But I think this is a really good reminder that we do need to really concentrate on being more receptive to consumers talking about these very issues, not just about HIV science and treatment issues, but about cultural competence, like we talked about at the retreat, and other issues. But this in no way should substitute for just conversations that happen at the consumer committee meeting or at these planning council meetings. I agree with that.
He's going to follow up with Sharon's, because I think it would be great if we can extrapolate the New York area numbers and responses, because when I see this fantasy here that treatment only 55% get it right. Technical knowledge, only 46% get it right. I think that it's was an opportunity for us to tackle those issues and not just take the report and put it somewhere else. If they take the time to do the survey and do the analysis, I think it's the next step will be on us to try to see how can we tackle what is regarding to the New York area. I know that it's not nationwide, but it will be interesting to see because these findings in here are very disturbing, and I think that as a council we have an obligation to do something about it. Whenever something crosses our desk, we have to do something about it, and I hope that this one will be one of those things that we can be used as an instrument.
So I just want to make 2 points, and one is just a comment on the survey as a whole, the other is specifically relevant to what Saul was talking about. What about the survey as a whole, I just want to mention, I did read one critique of the survey by Mark Harrington of TAG, commenting that this data, the data in the survey was collected in 2012. So it was a few years ago, not that long ago, but before all the emphasis on PEP and PrEP. So it is possible that if the survey data had been collected, say in 2014, when there's been a lot of emphasis on educating CBO staff and aid service organization staff and everybody on PEP and PrEP, the knowledge of the offline staff about biomedical interventions might have been higher than the fairly weak percentage here. The other point I wanted to make, which was in regard to what you're saying, is I would invite you, if you have a chance, to attend the Needs Assessment Committee meeting, because we have talked a lot about data there, and something we've been discussing there is related to what you're saying. We've been talking a lot about the burden on providers of collecting tons of data over and over and over for CDC, for HRSA, for HASA, for not HASA, for HAPLA, and so on and so forth. And a client who comes in and gets services sees multiple workers. Each worker asks essentially the same question, and so you're kind of saying in a different way, but to some degree paralleling what the workers themselves are saying. Namely, there's a lot of collection on data that's mandated for reporting purposes, but not the kind of data about the actual lived consumer experience.
I'll give an example. I've been talking about transgender. And I would, Daphne sent me in a survey from 2005, 2009. And in that survey states that, by 2005, the Department of Health requested that classification to start. Then I got another report from one who sent me one from 2009, 2012. This report spans more than 10 years. One has different data than the other. You can see it visually. And in connection, by luck, I was in the computer system, searching, and I got from the Department of Health a report on transgender community, done in 2010 in collaboration with, well, here comes the question. I asked Wong, and I imagine everybody's busy and everybody cannot have all the information in their heads. But I was able to gather data from one person and another person, and my own search. And in the 2010 report, it's data collection of you call it when it's not personal accounts. There clearly states the needs of the transgender community in a way that I think expresses quality. What the quality, not the numbers, not how many there are and what, but the quality they need. The survey, and I remember I was there last year when there was a presentation on transgender, and the girl said, well, we don't know what this data means in relation, the numbers mean, to why they are not in care or why they're not in care. The survey doesn't extend to that, or the data. When you see all the information that you have accessible, it doesn't take much to put it together and say, okay, there's a beginning here to spread. I mean, you already have that, you might be old, but there's stories that are told and you just need to connect them. For me as a consumer and interest in this community, it's just that I'm not a professional. And I feel that when I ask those who seem to have been here longer than I, and again, it's sort of the idea peer and say, okay, this is a consumer, he's interested, he wants to do something about it, let me give him a hand. Let me open the door. To signal him somewhere. To guide him. Well, it's just that. I want to, like I said in the retreat, I want to participate, I truly want to. I even made the decision sitting here and said, next time there's a vote, I'm not going to vote unless I know what I'm voting for. And I really know what it means. Because what's the point of being here? And so this idea of the children, I made it a point to investigate and go and knock the door of everyone I could in my own way to find out what is it that I'm not getting from the planning council that they're doing for children. Why are the needs assessments so, I know they have to be broad, but what is it that doesn't relate to what they're saying? Because I'm reading it, because that's what is printed from the Department of Health. So, that's what I'm trying to say. That as a consumer, I'm feeling left out in the conversation. And when someone, an expert says, here we have something important, everybody goes, and light bulbs. And so I feel, it's not that it's good, and I'm glad that you find that. It makes one feel, okay, what am I sitting here for? What do you want my vote for?
Yeah, so I want to say that the reason why you're sitting here is for you to express exactly what you're expressing now. And without you here, we wouldn't, like everybody at this table wouldn't hear that. And the questions and the concerns you're raising right now are why you're here.
I just want to speak a moment to the Hep C issue in the local pharmaceutical program, the consideration of that as a new priority. I'm going to assume that that would have to bubble up from the Integration of Care Committee, and then if a new directive has to be attached to it, it goes there onto the PSRA committee, put a dollar amount on it to go into the year 2016 application to HRSA. So HRSA gives us the award late all the time, so we're talking now, we're in the summer of 2016. We find out we have enough money to fund it. We have to put out a solicitation to implement it. I mean, we could be talking really maybe 2 years before it really makes a difference between, for these medications to be reimbursed. I think that we probably should have some more, some talks with the state around ADAP again. Well, I don't know what active conversations have had taken place other than in the PSRA with Christine Rivera. But I know it's too expensive, but if there was a way that we could attach a dollar amount onto the ADAP program, I know this would put pressure on the state because the ADAP program is a statewide program. The state would probably have to kick in money for the rest of the state. But in lieu of doing that, we're talking about a couple of years possibly away of the money actually hitting the streets. And people can't wait that long, for one thing. And then we're probably going to attract a lot of people from all over the state to come to New York City who are desperate to have this treatment funded.
It's difficult to sit here and know that there's a cure for FISC. Having lived with HIV half my life, and there's still no cure. So I think that it's a challenge for us to see and try whatever path that we may be able to explore to help provide people with medications that are a cure from ailment that they have. Locally assisted pharmaceutical programs have been in existence. They're a HRSA core service category. What we're attempting to do here is to explore that possibility. And what you presented to us is one of the arguments, pro and con, against doing or not doing this. But I think it would be tragic if we felt that we were so disempowered and unable to move forward in assisting people with medications if it wasn't within our abilities to do that. So I think that we should continue, as has been proposed, to write a proposal about what it would look like to establish a locally assisted pharmaceutical program, explore the idea that perhaps there's some understanding in some of the service categories through our portfolio every year, where those dollars could be moved into that service category to support co-payments for HCV medications. It's an idea. Let's explore it and see where we get. And if it's 2 years in the making, there are people living with hepatitis C in 2 years from now, as there are today, that will need that medication.
Well, we'll continue to keep you posted, but we'll definitely try to prioritize all the committee's work so that this happens sooner rather than later, because I think we do hear that the process can take quite long. So, I'm taking up too much time, so I'll just go very quickly through 2 letters that are in your packets. I think they all might out of order, but I think it was behind the Corey one. So these are 2 letters that the policy committee wanted to set forth to the planning council. The first one is about mail order pharmacies. If you remember, we set forth a virtually identical letter last year, and we approved it as a planning council and sent it. This year, we are hoping to do the same. Just to give you a little background. So currently, some insurance companies require that prescriptions be delivered by mail to consumers' home address to receive their HIV medications. Now, obviously, it saves money for the insurance companies, but it can cause a lot of problems for consumers. For example, if they live in apartment buildings, it can't accommodate package delivery, or containers are too large to fit in a narrow mailbox. Oftentimes, they become lost or stolen, which can compromise confidentiality. There's a lot of issues for consumers who are required by the insurance companies to receive their medication by mail. So this letter from the Planning Council is written to Mayor de Blasio, asking him to support some legislation here in the state that ensures that consumers are able to access their medications from local participating pharmacies should they want to. So we're basically asking, the legislation is asking that insurance companies allow consumers to decide on their own whether they want their medications mailed to them or if they want to pick it up at the pharmacy. So are we moving forward with a vote on this, or did we want to wait to give everyone a chance to take a look? Again, it's virtually identical to last year's. All that's changed is the bill numbers.
You're in a position as the chair of the committee to bring it forward as a recommendation, a resolution motion.
So as co-chair of the policy committee, I move that that the planning council approve this letter to be sent to Mayor de Blasio. Is that sufficient?
I second motion.
Motion on the table that the letter be sent by the planning council to. Okay. So there's a motion on the table from the policy committee to have this letter signed and sent to the mayor. And I'd like to open it now for comments. I see no comments. Actually, if it's appropriate, I'll just make one quick comment. Just yesterday, I got a call from a client who is actually an ADAP recipient, who was told by his insurance company that he needed to get his medications through the mail, even though he was going to the pharmacy 5 blocks away from his house to get his medications. For the last 3 months, he's been struggling to get his medications on time. And finally, after talking to me and reaching out to the state attorney general's office, he was finally able to get an exemption. It took him about 4 or 5 months to be able to get his medications where he should. This shouldn't be happening. The law actually states that people should have a choice, but in reality, the insurance companies and what are called pharmacy benefit managers are exploiting a loophole in the law to force people into mail order pharmacy. They get a message, a letter in the mail that tells them basically, you either use mail order or you pay for the medications yourself, right? I don't know how many of you have $2,000 to pay for medications, but I don't. And so this is what this is about. It's about closing a loophole to so people actually have a real option of using their local pharmacy if that works for them. Billy?
I was gonna say, 2 things. Number one, getting packages in the mail, I don't know about anybody else, but it's been like a hard story for me. I actually had to go online and look up packages that I had that said they were mailed to me and find out that they were in a mail, in a post office, like on the other side of town, so to speak. So if you got people getting medicine, and they're not even leaving a notice saying that they have delivered it, they made an attempt to deliver medicine. I mean, it's ludicrous. And so I think that number one, we need to change that. We need to seek legislation that will get rid of that loophole, and that may take time. But I think this letter should be sent to the mayor and wherever else it has to be sent to affect the change for everyone that's trying to get that. They had to yield to this policy of having it delivered to the mayor.
Any other comments? So, seeing none, I'd like to call a vote. All in favor, please raise your hand. All against? All right. Seeing no abstention, no one was against, so it passes unanimously.
So we'll follow up with this and track the legislation as it moves to the state assembly and senate.
And along the same lines, Lindell will be sending out a separate sign-on letter for other organizations to sign on to, so be on the lookout for that as well. Next week, I think you said?
By Monday. So look out for it. And what I want to say about that is that as a planning council, we can advise the mayor, but we cannot send messages, we cannot endorse legislation at the state level or otherwise, but individual organizations can, which is why I'm going to send out that separate sign-on letter. And a lot of organizations here at the table have already signed on, but the more, the better. So look out for that.
So the other letter I won't provide too much information on because we're going to save it for next month, but it's a letter directly to Bristol Myers Squibb, which in January 2015 increased prices for various antiretroviral drug products, notably Xgeva. And the letter is a very detailed description of exactly by how much it's raised prices and sort of under what circumstances. Now, we're not going to really discuss this further because this is still a draft form. Right now, Dr. Varma is still reviewing it and will get back to us with changes.
I have an update.
Sure. Oh.
We can move forward with this.
We can move forward.
It's not that Dr. Varma needs to approve or not approve a letter coming out of planning council.
Right, just his take on it.
This is a courtesy. I share this information with him so he's not blindsided when the reporter asks him about it. This is a very detailed accounting of what happens when AIDS profiteering comes into play. So you see a medication like Xgeva, which I've taken in the past, created in 1998, and the cost of that medication has increased 150%. So pharmaceuticals can raise the price of a medication year after year after year based on whatever criteria they seem to feel is appropriate for their profit line. And it's not pegged to some standard cost index. And so this letter talks about that and it explains it, and it expresses some degree of outrage about this, and also knocking on Bristol Myers Squibb's door to let them know that people are paying attention to this. Now, as I said earlier in the update from Croy, there are 2 new drugs coming out from Bristol Myers Squibb's, HIV drugs. How much do you think they're going to cost? The same challenge is taking place in the hepatitis C community with the cost of these medications. Later on top of that, with the frustration that it's a 12-week course of treatment and you're cured of the infection. So the whole discussion around fair drug pricing is not something we've talked about here before, but it's really come to the attention of the HIV community as a result of hepatitis C. And I think that it would be good to invite the leadership of the Fair Drug Pricing Coalition to come and talk to us and explain to us and offer us some avenues in which we can speak up. So this letter is speaking up that Bristol Myers Squibb. Mr. Anderetti happens to live on Park Avenue, or Bristol Myers Squibb is on Park Avenue, so there are neighbors here in New York City. And so this might have some meaning if we agree to sign on to this letter.
And as you review it, at the bottom of the letter, at the top of the reverse page, there are 2 requests that I think are very important. They're bulleted. You'll see that we're asking that they institute a price freeze for all currently approved HIV drugs for the next 2 years and for a 2-year period henceforth from the date of the FDA approval. And also that the company should take no more than 1 price increase annually and at no more than the rise of the medical CPIs. So do you want to go forward with this now, or now that we
can open it to discussion. Normally the process for this is that it would be discussed in the policy committee and they'd say, yes, let's make that recommendation. It would then go to the executive committee where it would be discussed there some more. And they'd say, yeah, we're in agreement with it. Then it would be brought here. But we sort of jumped ahead of the line and just brought it here. So if you want to adhere to process, then we can bring it back next month. And if there are those of you at the table who feel like you don't have enough information to vote on this, then we can table this until next month. Or if you're so duly moved to take action on this letter today, it'll be just as powerful a month from now, but if you want to do that today, you can do that as well.
Kathleen?
Yeah, I just have a question. Paragraph 4, when you say the price increase was perceived as proportionately inflated to be a triplet. Why is that? Is that because price wars, or, I mean, that's 2 different companies. What's that?
The triple combination is part of the triple. The triple is 3 drugs.
Oh,
Sativa and the 2 drugs are triple.
So if you just change the person in the triplet, that goes up because that's increased as well as you just take a triplet, that increases as well because the increase in the product. Okay, that's not good. If you don't know all of that stuff, you don't. I mean, okay, I got it now. So if one drug has another one in it, there's an increase in it, one increase. Right?
Right.
Yep.
That's absolutely insane.
Yeah, so that's the way it works there, because any of the single tablet regimens are combinations of the different single drugs. And so if one drug goes up, then
So
the
what's the point of
single
having a
tablet
single
goes up.
red?
It's easier to take.
Yeah, it's easier to take, but
Yeah.
it's like, it's going to price itself after a while, I mean, come on. Doesn't make sense to me, anyway. Yeah, send a letter.
We're trying to catch Sharon before she leaves here, so I don't know whether you choose to make a motion or choose to withhold.
why don't we wait until next month, unless there's any other strong opinion otherwise?
May I say something? I think that it's given the nature of this letter, I think that we should vote now because we'll send it out. I think that especially with 2 new medications coming from BMS soon, we need to send a message that we're watching, that we are aware of this price increasing. And if we wait too long, they will move to the next step on their own from the corporate perspective. I think that.
Sure. I mean, point
So,
taken.
do I hear a motion there?
Yes, as co-chair of the policy committee, I move that we approve this letter to be sent to Bristol Myers Squibb.
Yeah, just before that, Stephen had his hand up. Stephen had his hand up, I just want to make sure he.
Okay, is there a second to the motion?
I second.
Further discussion? All in favor of sending this letter to Bristol Myers Squibb? So say you. Opposed? All right, thank you.
Thank you.
So I want to give Sharon the opportunity to speak to her committee before she leaves.
Hi, everybody. I apologize for the PSRA committee met in March, and we also tackled the Hep C question, and we also took a look at the formation of the local pharmaceutical assistance program. That conversation emerged because we had asked Christine Rivera, who is the head of the ADAP program for New York State Department of Health, AIDS Institute, to meet with us and tell us about the impact of the implementation of the Affordable Care Act on the administration of ADAP. And we wanted to know what are the changes that Christine was seeing in ADAP in terms of the ways in which people was there an increase or a decrease? We had anticipated a decrease in utilization because of an increase of insurance coverage. So we said, did that in fact occur? And she said that there's been a relatively small impact on the way in which ADAP has been administered. She said that at the beginning of the year, a lot of effort is put towards helping people who are trying to get onto exchanges, and that unfortunately, because of the way that that process occurred, that many people fell through the cracks, and that ADAP had to cover them and ensure their continuation of medication during the period where they were waiting for the cards to come in and the new insurance system to turn on. She also said that in cases where there were savings to ADAP because they were no longer filling prescriptions, that ADAP was covering co-pays, and that was another way in which the resource was in fact still needed. So, I don't think that was me. Okay. So then we asked Christine about the Hep C medications, and given the advances in Hep C and given the fact that many HIV folks are co-infected with Hep C, we wanted to know was there any consideration by ADAP to add it to the formulary? And the answer, the short answer was no. That the research by ADAP showed that the cost of the new drug was about $100,000, and that the concern by ADAP was that it was too expensive and it would wipe out the ADAP resource and wouldn't allow it to cover the other HIV meds, and so the new Hep C meds are not on the ADAP formulary. So then the PSRA committee took a look at this local pharmaceutical assistance program proposal as a potential opportunity with the idea that we would, and in terms of the policy committee's summary here, I think that the PSRA is running too late. The PSRA would go back to ADAP because one of our responsibilities is to find out, not necessarily wait for new money, but also to see, is there an allocation that could potentially be reallocated? And one potential reallocation would be if there was a trend in ADAP, was there an amount of ADAP that could be moved away from the ADAP contribution and put towards a Hep C contribution through this local assistance pharmacy program. That would obviously require significantly more data and conversation with the state, which we do not have. We just initiated that conversation. So. But I wanted folks to know that discussion is ongoing. And so it was a very rich conversation, and both about ADAP, the impact of the Affordable Care Act, and about the Hep C meds. and this possibility of the local pharmacy. And then we concluded the meeting with a presentation by Public Health Solutions on the Rhine-White scorecard. And I don't know if everyone around the table has seen the scorecard, but it's this really incredible document. And yes, Sol, it has a lot of data that is quantified, not qualitative. So it does not tell stories of the people behind the statistics, but it does give us statistics about the breadth of our work, and it looks at the same information category, service category by service category over time, both financially, number of people served, and the newest addition to the scorecard is what's called the primary care status measures, which all service providers are required to report on in terms of number of people who you have connected to medical care, number of people who are viral load suppression, have seen their doctor. So that kind of data, I think it was the first time, it was an advancement in the scorecard, and it's a very comprehensive report. And I think that, and we really appreciated the time and the energy that PHS puts into developing that report for us. It's very informative. We did say, however, that we would like to have a qualitative report generated at least once every 2 years that does include focus group findings and interviews with people who are receiving the services, so that we can both tell the story as well as understand the outputs of the program in numeric terms. So that's the PSRA. Any questions?
I do enjoy that. Not a mistake. I appreciate it. I love it. But there's more to that story. That's what I was trying to say. But I do love that. I like the number. The graphs are beautiful.
Thanks all. Daphne?
We have an opportunity to get the full body to review that scorecard, that Rhine-White scorecard. Have a presentation on that. I would be interested in knowing how we're doing.
That's a great idea.
Yeah, that would be great.
Or we can invite Lauren Feldman
Yeah.
here. You can actually see the scorecards on the PSRA page of the Planning Council website. So if you want to take a look at it, it's 2 pages for every service category. So it's about 80 pages of graphs. But yeah, you can do the same.
Yeah, I just want to say on the Hep C thing, I think if you were to look at, we would have to look at understand how many co-infected Rhine-White eligible patients there are.
24%.
How much?
24%.
Are co-infected.
It's a rough approximation.
And then of those, how many are detectable Hep C viral load and eligible for treatment?
And uninsured.
Well, if they're Rhine-White, they're already, oh, no, not necessarily, okay. But I mean, even if you're talking about 5,000 to 10,000 eligible patients in the EMA, that's almost as much as the entire Part A allocation if you're gonna treat them.
We're gonna have to do the math, but it's about 5,000 people. Now, of those 5,000 people, are they all, tier 4 with liver conditions that would, put them in line for a liver transplant? Or are they, tier 1 where they have the infection, they're asymptomatic? All the reports out of CROI is hit hard, hit early. When it comes to hepatitis C, don't wait till the person's liver has been destroyed before you purchase these medications for them. So we're responding to what's happening out in the community. And part of the proposal will be doing a needs assessment, figuring out some kind of a cost, even if you're just being able to help with the copayment. And we see as more and more of these hepatitis C drugs come on the market, the prices are coming down. Not because of community outrage at the AIDS profiteering that's occurring, but because of the competition. And so, a year from now, we may be having a very different conversation about it.
Saul?
Just because you're right, because this is a story that is happening, being told in the community I am around. And, you know, one of the things that it's also augments the cost is when the first treatment doesn't stick because it doesn't work for you and you have to do another round. And that is happening quite often with the group I belong to. And I want you to consider the fact that even in the cost, you have to consider as well if that treatment did not fit that person. It didn't work for them. They will try another one if it's possible. Then the cost rises then, and a lot of them are facing that cost of going for a second round because the first one didn't work for them, and trying a different drug.
Thank you, Saul, and thank you, Sharon.
Thank you, everybody.
And so, as Sharon said, this is the beginning of the conversation, so something we're going to continue to discuss here. But if it's okay with everyone, I'd like to move on to the Integration with Care Committee and ask Nina to give a quick report.
Sure. So Integration of Care met Wednesday a week ago, and we too discussed the hepatitis issue. I'm not going to reinvent the wheel, but I do just want to mention 2 additional tacks to approaching the whole issue of the high-cost Hep C medication that we discussed. One was having somebody write an op-ed to the New York Times, and that was done by some colorectal cancer surgeons at Sloan Kettering regarding the unconscionably high price of some colorectal cancer medications, and they mentioned that their hospital, Memorial Sloan Kettering, was not going to be offering the medication at all because of the exorbitant price. A week later, the price went down. So it's another tactic in the potential tactic in the war on high pharmaceutical prices. Another possible tactic that Jim had mentioned was bringing pressure to bear on the New York City controller to include hepatitis C medications in the health plans available to city workers. By Jam's very rough estimate, there may be as many as 30,000 city workers who are living with Hep C. We also had a brief presentation on trauma-informed care, and we're going to have a full presentation on this at the next Planning Council meeting. I think it'll be exciting. We're going to have a panel. And just as a heads up, one sentence definition of trauma-informed care refers to 2 things. On the one hand, many patients who are infected with HIV have had one or more severely traumatizing experiences in their lives. The other side of the story is that people who work with people living with HIV also often become traumatized by the experiences and the pain and the suffering that they hear about on a daily basis and, take home with them at night. So we're going to be having a whole panel on trauma-informed care at the next Planning Council meeting, and I think that's going to be really exciting. In addition, we had a very brief conversation at IOC on the anticipated impact of changes in New York State funding on caseloads. Caseloads are going to be going up dramatically starting July 1. This is not a good thing. And we made changes in the Early Intervention Services Directive based on feedback that we got from the Service Committee at their monthly meeting. We are going to continue discussing and I hope finish the Early Intervention Services Directive at our meeting next Wednesday, April 1st. If we follow the pattern that we typically follow in the Integration of Care Committee, we will, I hope, finish discussing the directive, but put off the vote until our subsequent meeting so that people can review and reflect, and then we'll have a vote at the second IOC meeting in April, and from there, the directive will go to the Executive Committee and to the full Planning Council. And that's IOC.
Thank you, Nina. Any questions or comments for Nina? No? Wow. So, all right, so up next we have Carrie Davis and Danielle Castellanos to give us the update on the Needs Assessment Committee.
Carrie is going to be providing the report. I just want to make a procedural comment. We at the committee, and the Needs Assessment Committee, we are very interested on the needs of people who have but I see the issue of comorbidity. And we want to explore more the data available on their needs. However, when you were reporting, Carrie and I just found out that the needs assessment was going to be conducting that. So it's an issue of communication between the committees. I think it's very important that the committee has the ability to decide a little bit more the agenda for the committee. Of course, we are going to consider that as a request, and we will report back. Do you want to report that?
Sure, why not? So the Needs Assessment Committee met 2 weeks ago on March 12th, and we had a last-minute agenda change due to some scheduling issues. So we heard from the grantee staff about several documents that are submitted annually to HRSA, but were not previously shown to the Planning Council. The 2013 progress report on the New York EMA, the Part A implementation plan for progress report, and the MAI annual report narrative. And I was actually, sounds like dry stuff, but it was actually pretty interesting, and I was surprised by the number of questions that people had and how they dug into the material. We listened to an update from Kimberly Smith, who gave a really engaging and forthright overview of what was going on with the governor's task force and the pandemic, and I think a lot of people were really charged up and enthusiastic about how they might throw some resources from their organizations and themselves into that. And we started a discussion at the very, very end about products the Needs Assessment Committee could prepare for this cycle. And we did not get much into that topics. We only had about 5 or 10 minutes left at the end. And then we, at the last 10 minutes or so, we went on a tour of the newly renovated center. I urge you all, after tonight's meeting ends, to wander around. It's an open facility and it's a good center.
One more thing to add. When we have been discussing the quote-unquote products of the Needs Assessment Committee, we are very, very interested in getting the data that we have from each year and from the chain study into the hands of the consumers and the service providers. So that means doing some work in terms of the language that is used to communicate those results and those findings, and to make it accessible and to keep it updated. Thank you.
Yeah, I just want to say that what we're trying to do is look at the recommendations we made from last year's needs assessment report and turn those into action items that can be accessed through eShare and the Twin study.
Thank you, Carrie and Danielle. Any questions or comments for them?
Are you guys interested in increasing your Hep C consumers for your next meetings? I coordinate the meetings in the Bronx with the Hepatitis C Task Force, so I have a connection to a lot of those consumers.
It's possible we will be. We just haven't. This hasn't been on our agenda until it was mentioned today, so we're not sure how we're going to address the issue. So we just have to look into it and see if it's a fit with our committee, and if so, how we move forward. Absolutely.
It's all in play, Daniel, so I apologize if you were surprised. As the recommendations came out of other committees over the course of the last week, one of the suggestions was, well, we should do a needs assessment. And where would that be? Where would that live? That would live in the needs assessment committee. We should do a cost analysis. Where would that live? That would live in the priority setting committee. So all of that has to be negotiated with the chairs of those committees, and space needs to be found in their timeline of activities in order to produce that information.
Sure. I just don't want to give the council, the planning council, the impression that everything is set. As Adrian reported, that we will be conducting assessment.
All right, well, thank you, Danielle and Carrie. Now I'm going to move on to David or Billy to give our update on the consumer committee. David?
Yes. Our Consumers Committee met at ACQC on March 17th.
I think we had a really engaging meeting. But let me go back to our February meeting where we were informed at Boom Health. It was a little challenging, that space, but we took, we had some bumps in putting it together. But we were in a location where Service Direct, and thank you, Carlos, for organizing that. I think direct services are given in that situation, so we had a lot of individuals at that location. And felt put upon, I personally did, and I think the committee did, we had a lot of questions about things that were not under the purview of the Planning Council or the Consumers Committee, about more agency-related situations, why things aren't happening, what we should be doing, why are we here, and, well, definitely why we're here is something we could answer, but we were accused of not being prepared. And so it was it was an informing situation, so, like, when we have consumers committees, we don't prepare to educate everyone about the Planning Council and the Consumers Committee in our meeting. And we just have the meeting. So it was we took advice from that and decided to have a separate meeting where we could introduce the Planning Council and the Consumers Committee, so those individuals that had no idea of what we did could ask their questions. We could give them the feedback on what the Planning Council does and what the Consumers Committee does, what we're responsible for, and then go into a Consumers Committee meeting. And so that's what happened at ACQC. Unfortunately, we didn't have a great turnout for that introductory part of the meeting. We had, I think, 2 or 3 people come in, and we had a presentation scheduled for that. And instead of going through the entire presentation, basically we took the opportunity to engage those individuals directly. And I think that was the best approach, because even though we were able to give information about what the Planning Council does and what the Consumers Committee is responsible for, I was able to give a personal testimony, because I felt that at some point these individuals thought it was us and them. And I had to, gave my testimony about being positive for 27 years, and it was almost, it had impact, because the guy stopped and looked at me, and it was a little taken aback, and so then that led into the conversation about how they could be of assistance in, one of the persons was an outreach worker and worked in the pantry, I think another was a client, but how their stories are very important and how they need to be at the table, and how what they are around, the individuals that they're around, if they're at ACQC and they're listening to other consumers and they're hearing what's going on, they're partaking in what's going on, they could bring that experience and that to the Planning Council. So that was a really good meeting. And sometimes I just wonder why, in my position, I think it's a good thing to be at the table, and I don't understand why there are not a lot of consumers like running to the table to say, this is my story, why aren't you doing this, how can I help? Use my experience, but it's just not happening. So I don't know if it's about being visible, it's about being vocal, and I think the more of us who are vocal and visible, and not only in this setting, but outside, and I know it might maybe speaking to the choir, but maybe not. We did have an opportunity for Nina from IOC to introduce the Early Intervention Services directives, and we went through most of it. And I think that was maybe out of our retreat, we got some recommendations for those committees that are working on things to bring them to Consumers Committee so we can actually be a participant, as opposed to finding out at this full meeting and where we have to vote on things and maybe we receive the materials the night before or 2 days before. So we did come up with some recommendations, and they were well received, and I think they're going to also be implemented. also received from, I don't know if you're familiar with the Zero project, but they're doing a network empowerment project survey. And they're reaching out to people living with HIV groups to fill out the survey for the purpose of self-empowerment and reducing stigma and improving quality. And basically they're doing an inventory of existing people living with HIV networks and assisting those networks in strengthening them. So there is a link I have, it was forwarded to me by the staff of the council, and I encourage those individuals, I'll ask them to send it out to all of you, but it would be helpful for you to forward it to those other groups. And my last point was the feedback from the Power of Quality Improvement Conference. My portion of presentation was the workshop on the power of consumers in quality improvement. And I spoke to it earlier, so I won't belabor the point, but I think it's really important that when these entities that organized that conference put it together, that it was led with a providers and consumers improving care together tagline. But from the consumers I talked to, there really wasn't as much involvement of consumers as they had hoped. And the content wasn't geared toward the consumers as much as they had thought. And so it's really important that if you're going to use that consumer, buzzword, we're here. And as Sal said earlier, that sometimes consumers are a buzzword, and everyone seems to say we're client-driven or consumer engaged, but really it's their own perception sometimes of what needs to be done for consumers, not informed by what consumers think or need for themselves. And I think it's really important that to define and delineate those goals that you have for something like that. And I think that's it for me. If there are any questions, I'd be happy to answer.
Gil, you wanted to add something real quick?
I just want to add, the consumer committee meeting will be held from 1 to 3 p.m. at the Dining Center, 193 Wilson Avenue in Brooklyn. And they have consumers come out, and like David said earlier, you have a voice, come out and present that voice. Thank you.
Just 1 second. I do want to say that there should be, and we're still defining that time, there should be an intro portion to that meeting. So I'm working with Daryl on getting a time for those individuals who may be a part of the Family Center to come and get an intro to the Planning Council as well as the meeting. But definitely, please, there's a flyer that will be going out. But thank you, Billy, for mentioning that.
Okay, Carlos and Saul.
I just want to say something very briefly about engaging consumers or community, especially our consumers infected with HIV. So I work in the Bronx. The Bronx, we usually get the short end of the stick for a lot of different aspects of health. So it's very, we have food deserts, we have lack of housing, we have lack of job opportunities. So a lot of our consumers are working and they're doing their thing, and they're not really concentrating on policy or politics or anything that's going on in the community. So when we are doing this great work and trying to engage them, we have to take those aspects into consideration and how we're outreaching them. So some of the centers that I work in is a one-stop shop. So you get your medication there, you meet your doctor there, you get your food services there. Everything is in one place, so it makes it more comfortable for specific individuals. So when we are doing our outreach, when we're trying to include them more, we need to be innovative. So I'd love to be a part of that process when you start outreaching the community.
Thank you. Thank you, Carlos. Thank you again, David. And
So my report is really brief. The Rules and Membership Committee, I think we're up to, we have a full committee at this point. David sent an email out encouraging, asking if people were interested in joining the committee. Before we have our first meeting, which is Monday on the 30th, that people responded. So we now have a full rules and membership committee. First meeting will be March 30th from 3 to 5, and the goal of that meeting, amongst others, the real reason we're, the main agenda item is really for us to discuss bylaw amendments that will formally incorporate the Tri-County Steering Committee as a standing subcommittee to the Planning Council. And then there's other agenda items, but we don't have to go into those right now. But that's the main goal of this particular meeting. Okay?
Where's the meeting going to be held? Where?
The meeting will be held at New York City Department. Yeah, at Gotham Center. Right? Okay.
All right, thank
Okay,
you.
thank you.
Thank you, Daphne. Amber, sorry.
Sorry, I'm gonna make a very truncated report. I was not supposed to attend today, so I did not make alternate childcare arrangements. News from HRSA, so far we still have not received our final award, but we don't have an indication of when we can expect that to come. On our recent conference call, Stephen Young, the director for the Metropolitan, which is all the Part A's, indicated that not only would we now have to wait, we have to get in line because the Part B's also have to have their awards done, and so it could be a while. For those of you on the executive committee, you already know, for others of you may not have heard, our project officer, Michael Emma, who's been our project officer since just before I joined, has taken a new position and will no longer be our project officer at HRSA. And we have an interim project officer until they can find us a new one, and hopefully they'll give us someone great. Jan and I had a couple of conversations about what we're hoping to get in this. The best news, which I cannot get over delivering, after many years of battling with HRSA, HRSA has finally increased our flexibility, I believe is their terminology. We will no longer be requiring agencies to automatically calculate all of their rent as admin. So now they will have, using an approved methodology, we'll be able to associate program space costs as a program cost. For most of our agencies, this may be a big difference or a little difference. Many of them have already made other arrangements after the policy initially went into place, and so it'll be interesting to see, to reduce administrative burden. In New York City, PHS is going to allow agencies to redo their budgets at modification because they all just submitted budgets. Now give them a couple months to really think about what makes sense for their programs and how this could fit in with their competing priorities. In addition to the rents no longer being administrative costs, there's some staffing costs that they may also get to charge as program costs. So we'll know more probably after the budget modification process, which is August-ish?
August and September.
Yeah, so we'll know more then. Most likely what we'll just do is our actual administrative percentage will be less, and nobody's gonna find new costs because their MRAs aren't changing. And Public Health Solutions sent out a contractor news flash to this effect on Tuesday. Another big change has been, that's been in the works for a little while, is legal services. As those of you in IOC would know, and other committees have been talking about this for a while. After looking at some policy notices and some communications with HRSA, will now allow a very limited and very narrow band of legal services that have to do with immigration status, particularly to get protocol status, which will allow clients access to Medicaid in New York City. And you can read more about the details of that, and then we'll see how this actually looks once IOC takes on legal services later. So plain and simple. The Power QI conference, thank you so much, David, for your notes, and I put them down and I'll refer them back, but don't give too much feedback, you might end up on the planning committee.
Post-conference discussion, so it was a good,
Right.
productive.
Great. So we just listed here, in addition, so there was 180 people who attended, posters and presentations and workshops. And there was actually some voting, so these were the names of the posters that got first and second place in the voting, so you can see those. And we're going to be incorporating some of these posters and presentations into our provider meetings to make sure that that feedback cycle continues, and so that people who weren't able to attend the conference can learn about it. So our project officers, some of them attended, and they've been reporting back to their colleagues about what they saw and which presentations or posters. I know, for example, care coordination is going to have all the care coordination posters up during the provider meetings, so people can look at them during, because this is all they need, people can look at them during lunch and when they arrive, and really incorporate it back into our work, and not just have it be a thing that happened on one day. And again, we invite anyone and everyone who's interested to our interagency quality management meeting. That's a meeting between DOH, Planning Council, and the AIDS Institute. In April, it'll be on April 14th at the AIDS Institute offices downtown. If you're interested in receiving the agenda or call-in information, please contact Tracy Patton at the state. Her contact info is there. And I think that's everything.
Thank you so much, Amber, and I know you have to run. I asked everyone to bear with us for a couple minutes. We're going to postpone the strategic planning report because there simply isn't time for it. But essentially, we have Tom give us his report, and then we have 2 people on the docket for public comments.
So we at Westchester Department of Health are continuing to work closely with City DOH on a transition plan. We're having regular conference calls, and we're moving at breakneck speed to get all of our contracts executed as soon as possible in anticipation that the transition will be sooner rather than later. Now, of course, we get the change in policy on the admin, so that means we're going to have to probably get budget modifications to all 21 contract budgets, but that's okay. It's good news, so we're happy to do it. And that's it.
Okay, that was record speed. Next up, I'd like to invite, there are 2 people on who wrote down the name for public comment. First up is Barry Howard. Just as a reminder, we're going to give everybody a minute and a half. That's typically what we give everybody, so it's not like I'm shortchanging you. It's just like, and I will cut you off if you go over. Thank you. Barry, you're up.
Yes, hi.
Use a mic, please.
No, I'm good without a mic. I'm loud as I can be.
It's being recorded, so please use a mic.
You know, I can speak up, it's all right.
All right, go ahead. Go right ahead.
You want me to use that?
Yes.
All right. All right, I can go ahead with the microphone then. Can I use this one here?
Yes.
Let me.
Yes, please press a button and just speak into the mic.
Yeah, let me use this. Yes, all right. Let me just get back with everybody. Okay, welcome back, everybody. I know it's been a little while since I've seen everybody, so I appreciate being back here with Planning Council as well as the Executive Committee. And overall, I'm doing as well as I can, still very active in the community with many organizations, including the Department of the Federation of Mental Hygiene Committee, which meets every second Wednesday of the month right here at the community center. And they usually meet in one of these big rooms as well, and they discuss all type of LGBT mental health issues. So you're certainly welcome to attend that. Anyone is welcome as a guest. And it's the second Wednesday of the month from 3 to 5 o'clock here at the center. I'm glad to be back and welcome to finally, hopefully spring will spring, on a continued basis. We won't go back and forth with cold weather anymore for this coming season. And welcome also to the Queen's Pride House. The other program that I wanted to mention was the Queen's Pride House. That is the organization that offers many types of counseling information and counseling services in Jackson Heights, Elmhurst. So I wanted to make everyone aware that they're now on a bit of a leave. They're on a respite until June. So if you want to be able to apply for the services, you need to wait a couple of months until June of this year. And another 2 or 3 months, they'll be back offering full range of services. They do HIV counseling, they do GHMC, GHMC, the gay mental health crisis. They do that counseling. They do marriage counseling, physical therapy. So they offer a whole bunch of services. They're free of charge. They give you car fare to return and be able to compensate your trip. And they have a very well-formed budget, unlike a lot of other programs these days. Their budget is very strong, they're very well-funded, and they're available in the Jackson Heights area. If you're interested in applying for the services, see me after the meeting. I'll give you a contact number when it comes to June for Queen's Pride House.
Okay, thank you for sharing that.
Thank you very much. That's it.
Dominic?
Thank you, Council. Thank you, Barry. We all appreciate that. Just to make this really quick, I wanted to address something that Sal, I think, has been saying, and I've been wanting to get in touch with you, but every time I'm here, and then I look around and you sort of disappeared. So stick around, I want to exchange numbers because she's going to fly out of the room like a bat out of hell. But with that being said, talking about some of the studies that are not relating to the actual consumers, I completely agree with you on that. Right off the bat, 2012, we're basing some of these studies are, and they're not accurate as far as today's studies, as far as my drug activity was. Because many of you know that I was Hep C positive, but I actually got lucky. I got lucky and my body was able to fight it, and I didn't have to go on that deadly pill, which is why I fight so much. This is why I fight so much today. But I wanted to ask the committee, because I am new I am new in relations to all of this. Do you have any committees based on actually finding the cure? I know that you do all this work in regards to distributing the money out, but do you actually have a committee that is it within the realm of the AIDS planning committee to have a committee? And if not, shouldn't we? You don't have to answer that now if you don't want to, because
I think that's a great question. That's not what our funding is. That's what our funder provides us money to do. And it's a little bit frustrating. The dollars that we work with here are for people who have HIV. So we don't spend these dollars on prevention activities, that's another funding stream, nor do we spend these dollars on research activities, which is NIH and FDA funding streams.
Forgive my ignorance with that. And I also wanted just to ask, in regards to, you mentioned that the consumer had a day. I wasn't aware of that. Had I been, I would have definitely went there. So thank you so much for having that day to actually have for the consumers on Tuesday, to know more about what you guys do, as you referred to earlier. Consumers Committee. So thank you. I'll be going to the next one. And then finally, many of us at GMAC are really excited, although we're over there. We want to invite you back. We had a really good time when you came, and we hope that maybe the next meeting or possibly the meeting after, you guys can be our guest. Thank you.
Thank you, Dominic. And I just want to say, Carrie?
Just an update. Are people smelling smoke from here?
Yeah, there was I was going to say something, there's an explosion.
Okay, you can say it.
There's an explosion on 7th Avenue. Second Street. Second and 2nd Street in the village. East Circular building collapse and a fire. So, just so people are aware of that as we head out. So, With that said, I just want to thank everybody for bearing with us being over time, and thank you for coming. Get home safely.